Hello and welcome everyone to this webinar entitled Person-Centered Decision-Making in Healthcare and Care at End of Life. We have a number of participants joining us, and as our participants continue to join, we will start in with introductions so that we can quickly get through to the content. Next slide, please. I'd like to introduce myself. My name is Alex Bonardi. A visual description of myself: I am a white woman with shoulder-length, medium brown hair, wearing glasses today. Today I'm wearing a dark pink shirt and a black blazer, and behind me I am in my office with a lamp and a painting behind me. I'd like to welcome all of you on behalf of myself and Bevan Croft. We are the co-directors of the National Center on Advancing Person-Centered Practices and Systems. And thank you for joining us to learn about making person-centered decision-making for healthcare and care at end of life. These webinars are free and open to the public. Next slide, please. The goal of the National Center on Advancing Person-Centered Practices and Systems is to promote systems change that makes person-centered principles not just an aspiration, but a reality in the lives of people across the lifespan. And the delivery of webinars such as this is one of the many activities that we take on as part of this center. Next slide, please. A few webinar logistics before we get started. All participants who are with us today will be muted throughout the webinar. You can use the chat feature in Zoom to post questions to the panelists and to communicate with the hosts. And thank you for doing that. Towards the end of the webinar, our speakers will have an opportunity to respond to questions that have been entered in chat. This webinar is currently live captioned in English and Spanish. And to access the Spanish captions, there is a link that has been put into chat for those captions. This live webinar does include polls and evaluation questions, so please, if you can, be prepared to interact during those polling times. Next slide, please. At the conclusion of this webinar, you can reach out to us at the email address that is on the screen and is also in chat, ncapps@hsri.org. Please note that this email is not being monitored during the webinar. You can use chat if you have questions. This recorded webinar and PDF version of the slides and a plain language summary will also be available within 2 weeks on the NCAPS website, ncaps.acl.gov. Next slide, please. And to get started, we are delighted to have all the participants here. If you could, please take a minute to respond to the poll that we currently have up on the slide. This provides the speakers, our panelists, with a good amount of information to understand who is joining us in this conversation today. I see quite a number of people are engaging with the poll, and please know that you need to scroll down. There are a couple more response options towards the bottom of the poll, at least as the way it's being presented on my screen. We're getting a few more responses in here, and as you can see, I'll give a few more seconds. We've got over 500 people who have participated in the poll already. So looking at this, let us see what the results are. It looks like we've got a few people who identify as a person with disability and family members and loved ones of people who use long-term supports and services, self-advocates as well. The largest number of people joining us identify as social workers, counselors, or care managers, including, and then we also have representation from self-advocates, peer specialists, community or faith-based provider organizations, and certainly a number of government employees as well. We're delighted to have every one of you with us, and thank you for joining us for this important conversation. Next slide, please. And with that, I'm very pleased to introduce our speakers. We have two co-facilitators for today's conversation. Leanne Kingsbury is a consultant and gerontologist who's supported people with complex health care and disabilities for more than 30 years, and who authored People Planning Ahead, a guide to communicating healthcare and end-of-life wishes. The other co-facilitator, Mary Beth Lepowski, leads Helen Sanderson Associates USA, a learning and development consultancy that developed Living Well, a person-centered approach to supporting people to live well with a long-term condition and plan for care at the end of life. And we're delighted to have four esteemed panelists join us today. Reverend Bill Gaven is a theologian who examines his work through the lens of spirituality and faith. Julie Snyder is a community-based provider organization planner who will share her experience through the lens of community supports and services. Tora Good, whose research, writing, and expertise helps us better understand the importance of and the influence and implications of culture on the subject of advanced care planning and care at end of life. And Diane Coleman, an activist and executive director of Not Dead Yet, a grassroots disability rights organization that opposes legalization of assisted suicide and euthanasia as deadly forms of discrimination. We are so grateful for all of you to join us today. And with that, I would like to turn it over to Leanne Kingsbury.
Thanks, Alex. Hello, everyone. Welcome, and thank you so much for joining us today. I'm Leanne Kingsbury. I'm an independent consultant and trainer in disability and aging services and policy. My pronouns are she and her. I'm a white woman with short brown hair, and today I'm wearing red glasses and a sort of purplish sweater. And I'm joining you today from my home office. Over my right shoulder are some closed curtains that are kind of red and gold in color. And over my left shoulder is a bookshelf with books and photos and a photo or a picture hanging on the wall. We are really thrilled to have such participation today. We know that this can be a complicated and frightening sometimes conversation and topic. And we also recognize that trying to cover this in depth in about 90 minutes, the best we can do is really sort of hit high level and kind of scratch the surface. I'd really like to thank the NCAPS team also for suggesting this topic, even if we are just scratching the surface. It's a really, really important conversation. So I'm going to start off today by highlighting some critical considerations, things that if you're talking about healthcare decision-making, if you're talking about advanced care planning, if you're talking about care at end of life, really any of those, and they all sort of run together. If you're talking about that with anybody, in this case, we're talking about people who identify as living with a disability, there are some considerations and subjects that you really need to be comfortable with and sort of understand the implications of those. So I'm going to start with those, and then I will be handing it off to Mary Beth to begin our conversations with our panelists. To get us started, the next slide, please. Actually, and we can go one more. Great, thanks. So we know that these conversations are uncomfortable. We know that generally in the United States, as Americans, we are a bit antsy about these conversations. And so I'm going to offer you an out. And that out is, if the conversation that you need to have with somebody or the planning that you need to do with somebody is actually not about end of life, don't start there. That's the really hard part of the conversation, I think. This is a spectrum of topic and conversation and engagement. And you can start, in fact, you should start much earlier on assuming that this is not a sudden and urgent onset of critical illness where somebody is likely to pass away, we're going to suggest, in fact, that you start much earlier about conversations around support. And who is it that can help you make decisions? Who's in your life that you trust to help you make decisions? The fact is that we know that almost all of us, when faced with a really complicated, complex, potentially frightening healthcare decision, will choose to involve others in that. In a very frightening way, many of us Google first off, right? We get a diagnosis and we start Googling, and that's probably a really frightening path to take. But in addition to that, many of us will turn to a partner, a significant other, a sibling, a best friend. We will turn to somebody else and say, oh my gosh, I just learned this today. I just found out that I might have this today. And it really scares me and I'm not sure where to go. And now they're asking me to make these decisions and I'm not sure what to do. That's really, really ordinary behavior. And so expecting that someone with a disability would not be looking to their circle, to their family, friends, and others really doesn't make sense. So we ought to go into this assuming that people will want to engage others in helping them think about those decisions. But if you're not talking about end of life, again, that somebody is not facing at the moment an illness that is likely to be life-ending, then let's start kind of back ourselves up. Let's start with this conversation about who do you trust to help you make decisions? What's your backup plan if for some reason you can't make a decision? And that's not about questioning somebody's ability in general. That's really talking about what if you can't make a decision at that moment because something traumatic has happened, you don't feel capable of it, you don't feel confident in doing it. So there's that moment of, I want some help with this. Who is it that can help me? That's a much easier conversation to have than what do we do about end of life? We'll get there, but the starting point is much calmer and safer with the who's your backup plan kind of conversation. Next slide, please. So as we think about that idea of who do I want to engage in, or who does the person want to engage in decision-making, I want to touch on a few key considerations that I want you to be familiar with. And sort of build, this is the lens through which we are thinking about this work, okay? One is that everybody is capable of making decisions. There are different complexities of decisions. There are different standards for decision-making. Somebody who tells you every single day, if you are helping somebody eat a meal, that's part of your job, is you're helping somebody eat a meal. And you know that if you try to help that person eat peas, they are not going to eat them. But carrots, boy, they're all over it. They've made a decision. That's a decision. Now, obviously, that's a very different decision than, do you feel capable of consenting to a needle biopsy for, and head on down the line with a healthcare diagnosis there, right? Very different complexities of decisions. But the standard for the legal standard for deciding, making a decision about who your healthcare decision maker can be is also different than the ability to consent for a complex healthcare decision. I've planned with lots and lots and lots of people who can say, I want my sister to help me make a decision, or I want my best friend, or I want my significant other to help me make that decision. But they may not be capable of making a very complex healthcare decision. But we start from this place of everybody is capable, right? Obviously not, as I just said, not everyone who's capable of making a really complex healthcare decision. Again, most of us choose not to do that on our own. Capacity. So we're talking about the capability of making a decision. Capacity is a clinical issue. It is very different than competency. They weave together, they overlap, but they are different standards. Our intent today is not to talk about competency and guardianship, so I'm not going to spend a lot of time on that. I just want you to understand competency is a legal construct. Right? Court systems decide whether somebody is a competent or not adult. Capacity is a clinical decision. Do you understand the risks and benefits of the decision you're about to make? And do you understand the consequences of that decision? So if you decide to go one way, here's what can happen. If you decide to go another way, here's what can happen. Or if you decide not to make that decision, here's what can happen. So capacity is a clinical construct. Capacity in the space of people with disabilities and then layered with healthcare decision-making is really murky. You will hear lots of stories about people being asked to do a capacity assessment where the questions are things like, what's today's date and what's your address and who's the president? And that's not a capacity assessment. That's about, are you oriented to time and space and place? And that's important information. But it doesn't tell us if you have the capacity to make a decision about the appendectomy that you need, right? Capacity is about risks, and there's more to it. Again, I'm scratching the surface. Capacity is about risk and benefit and the consequences of those actions, okay? We also want to understand that the presumption of competence, the presumption of capacity, the view of people with disabilities as being capable adults with agency is also influenced by culture. Tora is going to talk much more about that, but we have to roll that into our thinking and our helping other people make decisions. As advocates, we've spent most of our time saying, you are a capable adult and we want to help you make decisions, or we want to support you in your decision making. There are cultural implications there where people and families will disagree with us on that. And that's something we have to learn more about and we have to be respectful of. We should be challenging and testing assumptions when somebody says people with intellectual disabilities, people with developmental disabilities are not capable. Right? That's where we should be pushing back and saying, okay, wait a minute, capable of what decisions? So peas and carrots are one decision. Consenting for an appendectomy or consenting for a liver needle biopsy is a whole nother level. But we should not start from the place of, oh no, you can't make that decision. We should be starting from, let's help you learn about the risks and benefits of that decision and the consequences of those decisions and move forward from there. When somebody has a guardian or a conservator, they've been, in the eyes of the court, the eyes of the law, they've been deemed incompetent. Again, we could spend hours on that, not our intent today. But even so, if you look at, for example, National Guardianship Association standards, guardians are expected to understand the interests of the person for whom they are the guardian. Guardians should be having conversations about what matters to you, what's important to you. How do I know about the decisions you might make, as best as I can, if you can't tell me, based on what I know about what is important to you? We don't want these to be blanket decisions without the engagement of the person. We're talking about healthcare decisions. We should also be considering urgency and significance. A question, one of my tips for you is to say to you, when you are in a situation where somebody says, we have to make a decision about, appendectomy is always an easy one to use, we have to make a decision about this appendectomy, we should be asking, is the decision urgent? Sometimes it is, but sometimes it's not. Now, sometimes we might have weeks and weeks and weeks, but sometimes we might only have 24 hours. But the point is that if it's not imminently urgent, we have to make this decision right now, then we have time to have conversations with the person and perhaps help them be capable of making that decision or help them participate in that decision more than if we just make the decision without them, right? If somebody is not capable, assume, this is walking through the parking lot texting, right? Looking down, texting, the guy driving the big red truck is texting also, and you get knocked down in the parking lot. Not terribly injured, not life-threatening, but momentarily, perhaps unconscious, have a concussion. in that scenario, somewhere, there could be the question of, are you capable of making a decision about your next your healthcare decisions? And if so, if you're not capable, then we want to make sure you have a power of attorney or a healthcare proxy. Right? Again, not going to spend a lot of time on that, but that's the reason we should start future planning, right? We want to be doing that work ahead of time. Last slide, or my last slide. Next slide, please. All right. The last piece of this, because I need to move on, is there are people that we will plan with who will not have other people in their lives that can help them make decisions. Speaks again to why we want to do this work well in advance of needing it, because we want to build intentional relationships. We want people to have relationships and people in their lives that can help them make decisions, because if not, the system will step in. Systems aren't bad, people aren't bad, but when a system steps in to make a decision, it disconnects from the person. And that's not what we want. We want people to be actively involved in these scenarios around their lives and their healthcare. I'm going to stop there, and I'm going to hand it off to Mary Beth to introduce our panelists.
Thank you, Leanne. And there we go. Thanks, Leanne. And we're going to pull the slide deck down for a little bit so we can do some introductions. So hi, everyone. My name is Mary Beth Lepkowski, and I'm joining today from California. I'm a white woman with shoulder length gray and brown hair and blue eyes. And today I'm wearing a dark green sweater. And I'm sitting in my office in front of my bookcase that is organized by color. So Bill, Julie, Tora, Diane, welcome, and thank you for being here. And thank you all of our participants for joining. I'd like to invite each of our panelists to briefly share a little more about your role and area of experience related to supporting healthcare decision-making and care at end of life. Bill, would you be willing to go first?
Sure. I'm sorry, but my
You're there.
says I am unable to start video, and I don't know what's going on. So let me do the. Pardon? Oh, there I am. Okay, great. Hi, I'm Bill Gaven. I'm a clergyman who's been working in the arena of intellectual and developmental disabilities, or between that arena and faith communities and service systems for almost about 45 years. And those roles have gone from the first 11 years where I was chaplain at a couple of the older institutional models that we used to have, and then director of family support for DD Council in Georgia, and about the last 20 years spent as working at the Boggs Center on Developmental Disabilities in New Jersey. My experience has been helping people with intellectual and developmental disabilities as they move toward the end of their lives, working with families, as well as the staff who worked with them. I was in New Jersey when I got there. I was in my role at the Boggs Center. I was fairly often called by an agency to come in after somebody had died unexpectedly at a group home or some other facility, which I was glad to help, but it was problematic in all kinds of ways, particularly because I was a stranger to most of those people. And one of the reasons for the importance of today is you hope that an agency and people will be able to call people who they know and whom they trust and have confidence in. I then at the Boggs Center for about 10 years, I did a quarterly day-long workshops for direct care staff, case managers, and other professionals on coping with grief and end-of-life issues and experiences. And we always asked the staff who came to say, why are you here? And what kinds of experiences brought you? And the range was just huge in relation to that. And so it was a wonderful way to hear from people about their experiences they were having, their concerns about it, and how they could work more effectively with the people they supported, as well as with other staff and families. So that's the background that I bring to this. I've done a little bit of writing in this area and speaking, but it's been a passion of mine for a long time, mostly because for a long time there was very little out there in terms of resources. And thankfully that's begun to change in the last decade or so. So I'm delighted to be here with this panel and on this topic today. Thank you.
Thank you, Bill. We look forward to hearing more from you in a bit. And I'd like to welcome Julie Snyder. And Elaine, will you please pull up the slide that Julie has to share?
Oh, I can use that slide and question 1. That would be better.
Okay, thank you.
Thank you.
We'll do that then.
Okay, great. Good afternoon, everybody. My name is Julie Snyder. I am a white woman with medium length blonde hair, and I'm wearing a brown shirt and sweater. And behind me are white cupboards and a clock on the wall over the door. I am a life planning navigator for Tierra del Sol in Sunland, California. We pride ourselves on being champions of inclusion and value for all individuals with disabilities. During my 31 years with the organization, I have worked side by side with numerous adults with disabilities and their families to plan and give support to them for all stages of life. I am a regional trainer with the NTG, the National Task Group on Intellectual Disabilities and Dementia Practices, and I am a certified facilitator trainer trained by Tamar Heller in the Future is Now curriculum for late life planning through the University of Illinois. Outside of my work, I had been a conservator and advocate for a 46-year-old gentleman with significant disabilities and autism. Last year, he passed away due to COVID. There was a lack of support and medical attention to meet his needs, and this was very unnecessary. This was a very difficult process and hard to understand how it could have all happened, but it was a new experience and it was further learning for me so that I can help many others. And this is the reason that we're all here today. So I'm hoping you'll find my information simple and practical and that you'll be able to use some of the things that I share with you today. Thank you.
Thank you, Julie. And Tora Good, would love to welcome you to our panel.
Thank you, and good afternoon to all. I'm Tora Good, and my pronouns are she and her. I'm an African-American woman with brown skin. My hair is styled in natural twist. I'm wearing my bold blue top and also glasses. As I think about what is role, not just on this panel, but how I've contributed, has really focused largely on healthcare decision-making and end of life. And this is, again, through the lens of culture, through the lens of language, and through the lenses of cultural and linguistic competence. And so I would say that my work has focused on expanding the literature, areas of professional development, and recommended practices, again, that take culture and language into consideration. I'd also like to note that I had personal experiences, both with healthcare decision-making and also with end-of-life care. And this included my father, my mother, and my youngest sister who had a disability and who passed away in 2020. So that my experience is not just through an academic means, it's through lived experience in my life.
Thank you, Tora. And it's my pleasure to introduce Diane Coleman.
Diane Coleman, founder and CEO of Not Dead Yet, a national disability group formed in 1996 to educate and advocate concerning end of life and specifically ending of life issues. I'm a white gray-haired woman, pronouns she, her, wearing glasses and a breathing mask, sitting in a motorized wheelchair with a red print dress and sweater in my den with white curtains behind me. In 2010, before I used this ventilator, I caught a severe flu and began to go into respiratory failure. We called 911 and Though coughing and struggling for breath, I spoke with the EMTs. But as they were rolling me out the door on a stretcher, they asked my husband, and NDY's research analyst, if I had a DNR. This concerned him greatly. Later at the hospital, they took a lung x-ray and my spinal curvature created a shadow that could have been a tumor. The doctor questioned if it were something, would I want it treated? His doubtful tone felt like a threat to my survival, so I blurted out, I have a full-time job. I felt guilty for resorting to that, but the doctor looked embarrassed and backed off. Over the years, I've been educated by several people in the developmental disability field that the number one targets of non-voluntary and involuntary withholding and withdrawal of life-sustaining treatment are people with intellectual and developmental disabilities, brain injury, and dementia. So my role, as well as my theme today, is one of cautionary notes. Thank you.
Thank you, Diane, and all of our panelists. I'd like to invite panelists to put your cameras back on. Thank you. And Leanne and I are going to pose some questions to our panelists. And the first is, we'd be interested in hearing about how you have used person-centered practices in your work around this topic. And from your unique perspective, how would you describe the value, the importance, and the impact of advanced care planning and having conversations about healthcare decision-making and care at end of life, perhaps before people are in a time of crisis? And Tora, I'd like to invite you to start off this response.
All right, those were two lengthy questions.
Yes.
I am going to give my responses in those two parts. So first of all, no supports or services can be person-centered unless they address culture, multiple cultural identities, and in the language of the person. And so I just think that is fundamental. And I have a really great quote. It's from Metcalf and Huntington in 1991, who stated, "What could be more universal than death? Yet what an incredible variety of responses it evokes." So that tells us, just in that quote, that we all have different beliefs and practices and ways of looking at end-of-life care, and including medical decision-making. So understanding not only the person, but also the person within the cultural context of their family, the community in which they live, and all of the medical decision-making and end-of-life care, because it indeed has a cultural basis as well. They're not culturally neutral, whether it's medicine, whether it's legal or other kind of supportive services. And so this is how the lens I would use to think about person-centered practices in my work. So do I go on to question 2, or you're switching back? Go on to question 2. So again, looking at the value and importance and impact of advanced life care planning. So as I think about that, it's important for us to really understand that many cultures are future-oriented, such as Western cultures like the United States, but there are also other cultures that are present-oriented. And so for some cultures, planning in advance about what may or may not happen in the future is not a typical practice. And so if we're, again, using a cultural lens, that we're taking that into consideration and what it would mean to support individuals and families in that situation. Moreover, if you look at the literature in this area, discussing death within certain cultures, some may believe that it hastens the onset of death, hastens its arrival, and so that they avoid talking about it. Now, while these may not beliefs and practices that you share as a professional, we still, as professionals and family members and people with lived experience of disability, need to be able to acquire knowledge about how different belief systems really affect how one wants to engage in this space. So I'll stop now.
Thank you, Tora. And I see people commenting in chat about your quote, what could be more universal than death, yet what an incredible variety of perspectives and responses. Thank you. Diane, how would you respond to those questions?
Well, a critical goal for that dead yet has been to help ensure that the withholding and withdrawal of life-sustaining treatment is voluntary. And there are real threats to voluntariness. First, when the person has decision-making capacity at the time a healthcare decision is needed, the concern is that there is informed consent and real choices versus being steered or pressured by others who may have a conflict of interest or deny options. When the person is incapacitated and a surrogate is needed to make decisions, the concern is that the surrogate was chosen by the person and decides according to their wishes. In either situation, we're concerned about anti-disability bias in advanced care planning. We often call this bias a better dead than disabled mindset. Professional advanced care planning training and boilerplate forms are full of this bias. The fourth issue is that doctors and hospitals sometimes overrule a patient or a surrogate's decision, unilaterally and involuntarily withholding life-sustaining treatment under so-called futility laws and policies. These types of concerns were discussed in the National Disability Rights Network report, Devaluing People with Disabilities, Medical Procedures that Violate Civil Rights. Quote, there are times where physicians recommend and family or other surrogate decision makers decide to not provide a needed transplant, to withhold medical treatment, including hydration and nutrition of individuals without a terminal condition. Applied in these ways, medical decision-making and procedures are discriminatory. Ethics committees and consultations are insufficient protections when there's a perceived or actual conflict between the desires of parents or guardians and the rights of a person with a disability. End quote. For surrogates who strive to save a loved one's life, some hospitals are even willing to go to court to remove them in favor of a more cooperative guardian who agrees to withhold treatment. Advanced care planning was a bandwagon driven by the healthcare system. As said in the Kaiser Health News resource article in your packet, entitled A New Paradigm is Needed, Top Experts Question the Value of Advanced Care Planning, studies show that the problems with advanced care planning apply to everyone with or without disabilities. Too often, it's become a checkbox exercise without in-depth discussions and too little awareness of its flaws. That said, yes, a trusted surrogate is needed. Yes, talk about potential support if medical situations change and revisit these discussions over time. But be cautious of a healthcare system that can be all too ill-prepared to provide even basic ADA accommodations and contains too many professionals who are all too ready when looking at current or predicted disability to write us off based on negative quality of life judgments that to them seem entirely self-evident. Thank you.
Thank you, Diane, for that perspective. Important considerations for all of us to consider. And Bill, would you like to follow up?
Sure, and apologize for the video blip earlier. I am a white guy with glasses and a gray beard and wearing a blue shirt and a blue jacket and sitting in front of a wall that's got a number of art pieces from Nigeria where I happen to grow up. So part of my background is multicultural from the very beginning. In fact, my early experiences with death were having people from the hospital who died and didn't have family, having them buried in our front yard in the compound where we lived. But even before person-centered planning even came into a parlay and a system of helping supports, I think pastors and clergy learned some lessons early on about the importance of person-centered planning and supports with each person that they work with. When I was a young pastor at a small church in the Bronx, right after seminary, we had 4 deaths the month after I got there, and every single one of them was a different culture. And every single one of them had different rites and rituals and ways of approaching that death that really taught this young clergyman a lot about trying to honor people's perspectives and their background and their culture. A lot of my early experience for years was about the absence of any kind of person-centered planning around death in services and supports for people with intellectual and developmental disabilities. First of all, to be honest about the fact that it even occurred. Lots of places and agencies would say, no, nobody dies at our place, and the question would be, where does that happen? And then you too often would see what I call grief piled on grief when someone did die in a service system or a group home or somewhere, because the assumption was that that must have been some kind of critical incident report, which then usually meant an investigative team, which usually meant then the assumption that somebody was at fault for this happening. Something must have gone wrong for that to happen. And you end up then in New Jersey, in fact, with a law that said at some point, if a staff member was found negligent, they could be fined something like $5,000. So just a whole lot of pressure there about getting things right. I think staff that I worked with at times also felt like death was a sort of double injustice to people with disabilities. Why did they have to have a disability in the first place? And then secondly, well, then why do they have to face death? Why does that have to happen? But like for many people who worked in this area, over and over again, the experience was hearing about people with intellectual disabilities not being allowed to go to the funeral of a family member who had died, or vice versa, when someone who was supported by an agency died, then the family having a funeral offsite or somewhere, and the friends and staff and others from the agency frequently not being invited to come to that funeral and support. So you saw the leftover gap and between institution and community there in ways that was, I think, really tragic for people not being able to be together. On the opposite side of that, I was able to help, to participate in and lead and sometimes help facilitate funeral services and planning that are really focused on the unique gifts of every person and individual who was involved and the people who they were around most of the time. And I can tell you that some of those which I would have called very person-centered were some of the most profound experiences of memorial services and funerals that I've ever been part of. I mean, one of the stories I heard in New Jersey was of a really good funeral home director who found out that this guy really was, well, the guy who died was Irish to the core. And so everything they did for the funeral, from the funerals, from the center for the room where the wake was, to the service and to the graveyard, was green. So the way of personalizing things and in other ways with people, having times where people can share stories. So my passion for thinking and writing and training about this and the importance of planning ahead in at least some ways comes from wanting to help all those of us involved to avoid their avoidance of it in the first place, the way that the system and others have avoided thinking about it and even planning for it, for the sake of everyone involved and the possibilities of really honoring people as they come to the end of their lives and the difference they've made on us and the people around them. Thanks.
Thank you, Bill. And Julie, now we'd like to share the slide that you have for us.
Good afternoon, everybody. These are some pictures that I'm sharing with you because they will be part of some of the stories that I will be telling. So this is Dean on the left here, and this is the two pictures in the middle. Is Karen with her mother, Shirley. And then the obituary, unfortunately for Karen, that her brother wrote after she passed away that created quite a buzz on social media. And this is Susan on the right. So all of my work is rooted, all the work that I do is rooted in person-centered practices and is basically hands-on. I believe that planning and a person-centered approach should be used during all transitions throughout life. What I have learned from older adults with intellectual disabilities and their family members is that there should be several stages and ways of planning. These stages are retirement, late life planning, and end of life planning. So what does retirement look like? Do you need a shorter day, a flexible schedule? Do you need to stop working? Using the person-centered planning process will help to discover and enhance their quality of life during these important transition times. It will help the individual and their circle of support visualize and take action towards how individuals with IDD can have flexible schedules and environments that meet their age-related changes. In late life planning, this includes parents and caregivers who will face a time when they can no longer care for their loved one. This responsibility often falls on the siblings, which can sometimes create a crisis in the family if plans are not in place. I use the Future is Now curriculum to help families and siblings go through a series of workshops where they can be in a safe space to express their thoughts, emotions, fears, and also their dreams. By attending this workshop, it helps them to create a letter of intent which documents their wishes along with all of the valuable information that needs to be known about their loved one and can be passed on to the successor caregiver. This ensures that the individual's routines and preferences are honored and continued. And then advanced care planning and end-of-life decision-making. As it is for many of us, end-of-life decision-making can be a process we avoid. Individuals with IDD are just beginning to be included in the end-of-life planning. It is up to us to have these sensitive conversations. Person-centered planning along with advanced care planning can completely support this. Throughout all of the planning stages, we want to keep their contributions alive and identify their gifts and talents, even as they decline and approach end of life. This will help their caregivers and medical professionals know who they truly are. The picture on the left is Dean. He had just completed his person-centered plan at age 74. Because of Dean's challenges to verbally communicate, he needed time to express his responses. As the facilitator, I met with Dean several times before he was ready to invite his friends and family to his formal plan. I had known Dean for 20 years, but by taking the time to have these deeper conversations with him and being curious and truly listening, we learned what's important to him and for him. At this time in his life, he understood how important his voice was. Together, we learned so much about his aging future and what it could look like. In all types of planning, it is so important to remember to manage our own emotions and expectations and to keep it about the person. And to always remember that it's okay to pause and wait for answers. And whenever possible, we should be offering various modalities for communication and talking to those who may know them best if the individual is unable to communicate some of their more complex needs or desires or be able to communicate at all. We know by certain gestures and mannerisms that they're making choices and decisions. As you can see, person-centered planning can be a meaningful experience for each individual when done by a skilled facilitator. Thank you.
Thanks, Julie. You know, we've heard from all of you, the theme of the benefit and the value of a person-centered approach to supporting people to live well at all phases and conditions throughout life. And we heard really unique perspectives about the value of, and perhaps the inherent biases, perhaps in advanced care planning and a systemized approach to that. So thank you for those initial responses. So I'd like to invite Leanne to join us and pose the next question to our panelists.
Thanks, Mary Beth, and thanks to all the panelists. We really, really appreciate your engagement here. Also, just kind of keeping an eye on the chat, and there's so much great conversation going on around alternatives to guardianship and supported decision-making, the role of PULSE. I mean, there's lots of great conversation happening in the chat also. So I am going to ask our panelists to share on the question of, in your experience, what have been the challenges and limitations when having advanced care planning conversations? And we'd like to start with Diane, and then after Diane, we'll go to Tora.
Well, by now, many have heard of Lisa Iazzoni's study, Physicians' Perceptions of People with Disability and Their Healthcare. Quote, in a survey of 714 practicing U.S. physicians nationwide, 82.4% reported that people with significant disability have worse quality of life than non-disabled people, end quote. As some of you know, in 1999, Not Dead Yet protested Princeton when they hired Peter Singer as their bioethics chair, who advocates a cognitive test for personhood and the civil rights protections that go with it. Let me share a disturbing comment from a 2004 Journal of Clinical Ethics article on brain trauma and surrogate decision-making. Quote, reliable information about the character of an injured person's future may be especially hard to find at those times during the course of treatment when there may be a convenient window of opportunity to stop interventions and allow the patient to die, end quote. The author is urging a rush to judgment, something a leading neurologist, Dr. Joseph Fins, is deeply concerned about. You should check out his book, Rights Come to Mind, which I didn't think to put in the resources, but could send after. That's some of the context in which advanced care planning will be implemented. Within that context, I'd like to point to some specific issues. First, from a federal health and human services document entitled Advanced Care Planning Preferences for Care at the End of Life, stating, quote, research indicates that patients often change their minds when confronted with the actual situation or as their health status changed. Some patients who stated they would rather die than endure a certain condition did not choose death once that condition occurred, end quote. Another issue is sometimes called terminal uncertainty, the difficulty of predicting terminal prognoses that may activate an advance directive. Even with the best intentions, a mistaken terminal prediction can trigger a mistaken withholding of treatment. There is also a concern that abusive relatives may become surrogates. For the last decade, every March 1st, disability advocates in cities across America hold vigils to honor the lives of disabled people murdered by their families and caregivers. According to the Autistic Self-Advocacy Network, there were 60 such cases in the last year alone. Finally, the history of advanced care planning, which partly arose in response to overtreatment at the end of life in the 70s, leads to provider assumptions that if you have a PULSE, DNR, or advanced directive, it must mean that you want to decline all treatment except comfort care. A series of studies conducted by researchers from the University of Pittsburgh Medical Center one involving survey responses for more than 700 physicians in 34 states, found that over 50% of physicians misinterpreted a living will as having a do not resuscitate order when it did not. About the same percentage overinterpreted DNR orders, or do not resuscitate orders, as meaning no treatment except comfort care or end of life care. These are some of the issues we should all be aware of when engaged in advanced care planning. Thank you.
Thank you, Diane. Tora?
Yes, again, I'm going to use a cultural lens. And I have 4 areas perhaps to focus on in terms of advanced care planning. But we should also remember the content that I shared previously. So autonomy is one. So as you think about conversations around advanced care planning, how is autonomy determined within the cultural context of the family, the person with a disability, the legal system, and the medical system? And they're all different. And so as we think about challenges, being able to look at each of those perspectives through a cultural lens, again, can be daunting oftentimes. Another is truth telling. And we talked about this earlier, that in many cultural communities, that there may be a practice of not sharing bad information, bad news, or serious illness with the person with a disability. And so again, this is a key area where we're talking about having these conversations. So when would the conversation happen? How would it happen? And by whom is the information conveyed? These are all things that happen within a cultural context that have to be taken into consideration. Again, maybe not for what you may be trained to do, but again, we're looking at cultural reactions to that. The third is informed consent. So I'm thinking about this again through a cultural lens and also language. How is informed consent obtained? In what language? And this is an area that we do not do well in, even though we have requirements to ensure that we meet the needs of persons who speak languages other than English or have limited English proficiency. And so again, what processes are used around informed consent? The last one is really control of end of life. And again, who is in control? That really will be determined culturally. Sometimes by the person with the disability, sometimes not. And then what are the implications of this for the family within the legal community and within the medical system? And we've heard some very scary statistics and studies cited by Diane. And then again, as we think about control over end of life, in particular in having these conversations, I want to bring up age. We kind of think about end of life as people older, like me in this category, but the lives of people with intellectual and developmental disabilities in from birth through old age. So really looking at age, what does this mean for children? What does it mean for adolescents? These are all cultural factors that we're talking about when we think of having these conversations.
Thank you, Tora. And we're going to move on to Julie and then Bill.
As we know, this is the first generation of adults with IDD who are living a normal lifespan and will most likely outlive their parents or family members. Because individuals with IDD are now living longer, systems and services are currently underprepared to assist the individuals and their families with identifying their upcoming needs to create an in-depth understanding of the challenges facing this population and the plans that need to be made. I've had several opportunities to support individuals with IDD and their families or parents in a hospital or skilled nursing facility. I have learned that those working in the hospital setting or skilled nursing facilities need further training and education to avoid making assumptions and to better understand their support needs. It is critical for the medical staff to know who the person is or was before their decline, their vibrant self. Were they an artist, a loving family member? Did they hold a job? When I first get involved in a case, I try to get to know the nurses. I find that they really appreciate having a go-to person, and they find it beneficial hearing about the individual and knowing more about them. I also like to write up a short description of the individual, pointing out their strengths and how they communicate best, or anything else you might want to include. It's important to include a picture of them in the description that shows them at their best. This helps hospital workers and doctors to see the person's individuality so that they can better relate and care for them in a more compassionate way. I give a copy to the nurse for the chart, and then I ask that a copy be posted by their bed for other medical staff who are coming in and out to be able to see. In regards to housing, there are very few accessible and affordable housing opportunities for those that age, especially for those with Down syndrome and dementia. And consequently, many older adults with IDD end up living in skilled nursing facilities at a ratio that doesn't meet their needs. Traditional group homes often have regulations which may make the adult with IDD who is older become ineligible due to their unique support and self-care needs, as well as increased behavioral and medical issues. All of this is to say that these factors can cause unwanted and unnecessary relocation away from a familiar environment and separated from people who care about them and understand them. This can be especially disruptive to individuals with dementia. Within the case management system, the vast majority of case managers need support and training themselves to adequately support the needs of older adults with IDD. Nationally, the number of adults with IDD at age 60 and older is projected to double by 2030. By age 60, about 1 out of every 16 adults with IDD will be affected by some form of dementia. There are not enough case managers, and caseloads are usually large, making it difficult to be able to have sensitive conversations and to really take the time to dig in and plan in order to provide the support and resources needed. We need to make sure that individuals with IDD are included in their medical decision-making. They need better access to have preventative medicine and preventative health care opportunities and specialists. Let's fully include individuals with IDD in the meeting process. I still see people talking about people with disabilities, not with them. Let's really be aware and advocate when this is happening so that they are at the center of their meetings. Research shows that there are an estimated 900,000 families in the United States in which an adult with developmental disability or intellectual disability is living with an aging family member with no plan in place for the individual's future. We really need to do better. So I'm really happy that we're having these conversations today. Thank you.
Thanks, Jolie. Thanks so much for your stories. We'll wrap up with Bill for this question.
Yeah, mostly I want to say amen to several of the things people said, but in a slightly different way. Let me go first to the issue about cultural diversity. It's not only people who come from diverse backgrounds, but in a lot of the country, people from an incredible diversity of nationalities and backgrounds are serving as direct care support staff in residential living programs, and they come from different ethnic, religious, cultural backgrounds. Those beliefs that they grow up with shape their practice even more than they might be aware of initially as they get into being support care and caregivers and direct support professionals. But taking that into consideration around end of life issues is really more important, because you get to a time like that, that's where real differences might erupt. At what you're doing this is you're trying to, in terms of that's just shocking or heretical to their backgrounds or beliefs. So it's so important to have some conversations about an agency's policies and their practices and honoring the person-centered differences among staff, as well as the people whom they're supporting. I think direct support professionals often feel like a fish in strange waters at times, and especially when they get sent into the hospital to be the person alongside a person who doesn't have a family member or others to be with them. Third, going back to what Diana said, I think hospitals are dangerous places for people with profound and severe intellectual and developmental disabilities. They run into a lot of professionals who think they'd be better off dead anyway, with the quality of life concerns. And what's one of the impacts of that is that they do not see the depth and breadth of the relationships that person may have with people in the community. Because people living in the community now, those persons may have touched the lives of hundreds of people, literally, and they have no awareness of how other people around that individual in the hospital sees them as a valued person and part of them, a part of that. Peter Smith, a neurologist in Chicago, a friend of mine, said almost every ethics committee discussion involves something related to cognitive ability. So this is one reason why supported decision-making is so important, and also helping people see the personhood there. Two things about how to do that. Look up online, if you've never heard of them, the healthcare passports that were a sort of person-centered plan to use to put next on a bedside next to somebody with a disability who's in the hospital. And there was an agency in New Jersey who came up with a brilliant idea. They didn't want to put anything in writing, so they used a big balloon and wrote up all the qualities of that person and what that she liked and some of her things on that balloon, so the staff would see it when they came in. We continue to face the challenge that people think people with intellectual and developmental disabilities are not going to understand talking about death or dealing with it. And the thing I would do here is, my suggestion was, about any time somebody asks a question about people with IDD about this or that, is to reverse the question and ask, how much do we understand fully about death and what's happening and our feelings about that? And if we're true, if true to ourselves, a lot of people are reluctant to think about that and to talk about that. And just because you have trouble finding the words to say it, that's an indication of, talk about it is an indication of how important it is. And we're also ignoring then that people with IDD often swim in currents of grief and loss around them. They're more experienced with grief and loss, I think, than many of us have been in our own lives. And I think finally, I think we're moving past a time when people used to think that, well, if somebody moving towards the end of their life and dying was really antithetical to the whole developmental process. Our whole system in special ed was to help people grow and develop. Well, what happens when we're going down the other side, so to speak, and that's growing system struggles with what to do. And that's why person-centeredness is so important. Thank you.
Thanks, Bill. Thanks to all of our panelists. Bill, I will tell you that one piece of advice around when somebody says, but they won't understand, and your response being, do any of us understand? I have used that advice over and over and over and over in all of the work I've done. It's just been so powerful. Thank you for that. I am going to turn off my video now, and I'm going to ask Mary Beth to join us for our next final set of questions.
Thank you, Leanne, and everyone on the panel. So you have given us a lot to think about in a short amount of time. And as Gloria has shared in chat, this is a powerful and much needed conversation. So we have a wide range of listeners today, and I invite each of you to share what is a piece of advice that you would want to share with those who perhaps are just getting started in supporting others around this topic. And Julie, will have you begin.
Thank you. Well, in my pictures, you saw a picture of Susan on the right, and Susan lived with her mom, and her mom was in her late 80s. And then sadly, Susan developed signs and symptoms of dementia. This progressed rapidly and required her to stay at home in bed. She and her mom both needed support, so Susan's sister moved in, and this allowed Susan and her mom to stay together in their family home. She helped this helped her mom to feel like she was still the primary caregiver for her daughter, who had always been at the center of her life. The advice is that, you know, what we learned from this is that planning, the planning that was to come, needed to be family centered. So we still would involve Susan, but we would have the case manager and the family, and we would have regular meetings to maintain Susan's quality of life. And these meetings were really important too, so that we could reassess and respond to her decline and her changing needs. The mom made sure that Susan had all these special touches. She made her hospital gowns out of Susan's favorite pajamas. And you could always hear mom talking to her while Susan's favorite jazz music was playing in the background as she was making her transition. And after her passing, Susan was honored by a service at her family church where she had an amazing tribute, just like anyone else who was a valued member of her culture and community. And then recently I was able to assist somebody who was a woman 40 years old. I helped her to create her advanced care directive. This was the first time for me doing this, so we sort of did it together for the very first time. And I would highly recommend supporting someone to do this. This woman is typically very shy, and she would probably only do this with somebody that she really trusts and had known for a really long time. And I knew that it would take a lot of time. So what we did was I would suggest that you meet over a long period of time, like maybe 6 weeks, and meet each week at the same time, just take an hour to start going through this advanced care directive. I used the one from Stanford University, and that was specific to California, but you can always just look up your state and find one that works for you. This form was laid out and perfectly and made so much sense, and it was so easy for me as the facilitator to do it and for her to understand. It had all the definitions and the medical terminology and the procedures that might come up, and it had check boxes and pictures. So it really worked well. It explained everything really clearly. And this individual chose 2 agents instead of 1, and also decided that she wanted to honor her Jewish faith for her burial and be with her family. Anyway, it's just really critical to help individuals with IDD plan what they prefer to do as they age, and make sure that we're asking the right questions in the right ways. Let's make sure that we're not taking their compliance to their routines and living situations as enjoyment or contentment. Don't be afraid to have these sensitive conversations. You know, parents and caregivers, you may want to avoid this topic, but please allow someone to gently sit with you. We'll just start out by asking some basic questions that are non-threatening and help you to feel comfortable. One thing I did with a mother that was very uncomfortable with this topic, was really hard for her to fill out a letter of intent herself. She got very overwhelmed. So I sat down with her, and I just asked her to go from head to toe. So where does your daughter get her haircut? Does she have a seizure disorder? Does she have any problems with her ears? Does she see the eye doctor or wear glasses? And then you just go all the way down through the person's body, and honestly, you cover everything. What's their favorite clothing? Do that you buy shoes in the special place? When they take a bath, do they, like to have music on? So just asking, and it helps you as the person supporting that parent to get through the conversation, honestly. And we need to be having these conversations early on, as everybody has said, as difficult as they are. And we really need to be aware of people with Down syndrome and dementia and start those conversations and the testing early to find out what their baseline is. And just always looking at rule outs for people that are aging. Let's not assume it's dementia. Be the voice and dig in deep to find these things out. And I just want to end with a story about John. Probably the biggest lesson that I ever learned. And that was John's had lived with his mother his whole life. He was probably about 45 when I had to sit down with him and tell him that his mother had passed away. And I thought I was just, doing that with him because it was the right thing to do. John was somebody who communicated by gestures and by jumping up and down and making noises, and usually needed one-to-one with him. And so I sat down with him and I told him that his mother had passed away in a gentle way. And I looked at him and there was a tear coming down his cheek, and then more tears coming down his cheeks. And at that moment, I realized he understood everything I said. So please always keep that in mind. Thank you.
Thank you, Julie. Bill. You're on mute, Bill.
Several things that I think I want to say them, try to be concise about this. Pardon the professional plug, but this is one area, one reason to take spiritual supports really seriously and spiritual connections. And if we're not exploring people's spirituality as part of person-centered planning, I'm not saying religion, it could be religious, but it's not, but their spirituality, then we're not doing person-centered planning well, because that's where we're missing an area about people that is answered, where people answer those questions of identity and purpose and community and things that are so important. Death doesn't happen to a person, it happens to a community in a sense, and people around them. And the importance of getting, if the people want to be connected to churches or synagogues, get them involved early so that they know. A couple of the worst funerals I've been to with an adult with intellectual and developmental disabilities is where an agency didn't know anybody and they did a rent-a-preacher thing to run the funeral. And it was just awful because there was no individualization of that at all. There are lots of beginning to be resources out there. You've heard some of them, the Thinking Ahead About My End of Life. In the resource list, you'll see some great books for adults to help sit and talk with adults, one called Books Beyond Words that come out of the UK to help people talk about death and their own death and deaths of others or parents. Australia has got a great website on death and people with intellectual and developmental disabilities. And I'm involved with the Hospice Foundation that's going to launch a website for autistic adults on dealing with grief, loss, and end-of-life issues in just a couple of months. It may be really important agencies to talk with prospective staff about this area and help them realize that that's something that they may face. Because I think one of the things that needs to happen is as people move towards the end of their life in our services or supports, we need to be able to step out of our professional roles and say something to them personally about what they have meant to us and with the gifts they've given to our lives. Because if they don't have a big community of friends around, when we say somebody can't call us a friend, we're taking the power away from them. And if they think that I'm their friend, whether or not I think that they really should have other friends is besides the question. And the question is who's going to be there that they know and care about at the end. And again, start early. And I would say by that, start when people enter an agency, services, and supports to talk about with a family how they've handled grief and loss in their family, not to plan ahead to the end of life stuff, but how have you handled grief and loss? Because that starts a conversation about here's what we do as an agency. We try to be proactive about it. These are things that happen. Somebody dies in your family. We'll bring somebody with your son or daughter because we think it's so important for them to be involved. So start that early on. It doesn't have to be about the end, but start talking about grief and loss, the culture around grief and loss in that particular family. Thanks a lot.
Thank you, Bill. And Tora. Oh,
No,
and then I'm sorry, let's go to Diane and then Tora. My apologies.
What I'm about to say is in my capacity as an advocate. I have a JD, but I'm not a lawyer now, and I never practiced in this area. But I would still say, the point is your healthcare proxy, not only someone who cares about you and can be trusted, but someone who has the psychological fortitude to resist a medical authority figure who may pressure them to make a decision you would not like. And they should either have advocacy skills or have advocates available to help, possibly on short notice. We've had calls from people on a Friday who were just told that their loved one's life support will be stopped on Monday, 3 days later, which left them shocked and scrambling. If you might face a medical emergency like that, your proxy will probably need a lawyer to help. Be cautious about forms for living wills, like checkbox forms and always never statements. For example, many forms say no ventilator, but what if you choked on something or got COVID or anything temporary or unexpected? As the Kaiser article in your packet indicated, some people died of COVID because their advance directive said they refused a ventilator, but what they probably meant was a permanent ventilator. Or maybe they didn't want intubation, but would have accepted a breathing mask type of ventilator if they known it was an option. People can also use waiting periods and try a treatment for a while to see how it works, but that's hardly ever in any of the boilerplate forms that are out there. Many advance directive forms also combine the proxy and the living will forms into one thing. In my view, and I've done this for myself, it may be safer to separate your proxy form and your living will type advance directive and then only share the proxy with your doctors. Assuming you trust the proxy, you needn't share the living will advance directive with doctors unless necessary. Don't give them a document they might be able to use against your proxy, especially if the directive has a lot of legalese or something that could confuse providers about what you really want. Regarding post forms or physician orders on life-sustaining treatment, be especially cautious because these are checkbox forms that are a valid medical order. In one post effort I was involved in, 2 doctors thought it best to only use post if you're sure you don't want life-sustaining treatment the next time the need arises. The final idea that some are recommending, which goes along with, I think, something I heard from some of you today regarding the photos, is to recommend considering a short video, even just something recorded on your phone that describes kind of who you are and what your life is, and maybe summarizing the care you want with, something that's consistent with your directive, and use that as a video to accompany the complicated documents. Thanks.
Thank you, Diane. And Tora.
Given the time that we have remaining, I will be as brief as possible. So as I think about what I'd like to be able to share, I'm going to look at this from 2 levels, one at an individual level and one at an organizational level. So I think one thing that we can do, again, using a cultural lens, is to really look at acquiring cultural knowledge about medical decision-making and end-of-life practices and beliefs among racially, ethnically, and culturally diverse persons with intellectual development disabilities, their families, and the communities in which they live, because it's all connected. And in absence of having that information, we would be presumptuous to know how people want to be supported. And then if we look at the organizational level, I think it's very important, and I heard Bill speak to this and others, to really look at within your organization to identify and begin the process of modifying policies and practices. So in other words, they're codified in policy and practice that really promote cultural congruence and end-of-life care and decision-making. Now, that would be in all instances, with the exception of those that may violate state, legal, or regulatory requirements. The other I really want to emphasize is that we have many people in the United States, that don't speak either English at all, or who are not using words as a primary means of communication. So we really need to be able to have that in consideration as we look at end-of-life care and decision-making, including people who may speak languages other than English. And I have one last thing I'd like to say. Language is so very important. I indicated that culture and language are intricately linked. You can't separate them. Really very quickly, if we, someone shared this with me when I had a loss in my family, and it was a book, and the first chapter was titled Language. And I thought, what is this about? And in the English language, there's not one word that a parent has that will say that they've lost their child. We have a word for it for a widow. We have a word for it for a widower, but it forces us to tell the story. I met a parent who'd lost a child, as I have, and one of the things that we looked for is like, what is a word that would describe this? And she was a researcher at Duke, and she found this ancient Sanskrit word called viloma, V-I-L-O-M-A-H, and it's against the natural order. It's because we do not ever think that our children should precede us in death. So not only is it a belief, it is the language. And so we have to figure out how we communicate these complex things in a way in which all members of families, the person with intellectual and developmental disability, and others around can truly process and understand.
Thank you, Tora, and thank you to all of our panelists. We're very grateful for your perspectives today, your practical tips, and your wisdom. There have been some great questions in chat, and given our time, Leanne and I are willing to follow up to make sure connections are made where it makes sense to do so. And if you want more training on this topic for yourself, your families, or care managers, Leanne and I are going to be offering training on this using person-centered approaches to facilitate conversations about advanced care planning and care at end of life. And there's a link in chat. If you're interested, the dates are not set yet, they will be set soon, but if you're interested in just staying connected around this topic and being notified of this training and other opportunities as a follow-up, please use that chat and link just to add yourselves to a notification list. And with that, I am going to hand it back to Alex, who's going to close out our day. Thank you.
Thank you, Mary Beth, and thank you to our co-facilitators and particularly to our panelists for joining us all today. At NCATS, we want to learn from you and to continue to get better. We have included a post-webinar evaluation, and we would very much, as we close up, please respond to this evaluation. We'll be leaving it up for a good while. And please know that you also, again, need to scroll down. There are 6 questions. As people are responding to the evaluation, I will just once again express my gratitude to each of you. This touched me both personally and professionally. We live the life, we talk the talk of person-centered practices. And the quote you commented on, Tora, about how death remains a universal experience, it absolutely is for each and every one of us, but the experiences for everyone can be entirely different. And in the work we do, in the person-centered work we do, this is just something that we have to continually build these conversations. Leanne, Mary Beth, thank you for the work and your leadership in this together, and thank you to each of our panelists for your leadership in these important discussions. And with that, I'd like to say thank you.